ready for another club webinar. It's number 57. You're going to have to share with us your ideas how we should celebrate number 60. That'll be just a few weeks away, right? So in the club webinars, it's your questions that we investigate and research. We had a lot of things come in, but of course, I get to pick, and I picked coding dementia. We had some questions specifically come in about how we could tell one dementia from another. Some of the wording, I think it really matters if you go look it up in the index and then go to the tabular. These were more beginners questions that had come in. We do those also for our student webinars. Don't forget, we do student webinars as well as the club webinars. But we have all levels in the club. We have beginners, we have people just interested in coding, possibly for a career, and we have established coders, and we have specialty coders and subject matter experts. So coding dementia is something that's really important because it risk adjusts. And as we move more and more to the diseases and the disease process carrying weight as far as being reimbursed, especially from Medicare, then we want to make sure we get to the highest specificity for these codes. So details to get to the highest specificity, that's what we're going to talk about. And if you have not already joined the club, this is how you do it. It's real easy. Go to cco.us. Let me start over. cco.us/club. Lots of great things in the club where you can ask these questions and get answered, but we could also turn it into a club webinar so that we can do a recording and help lots of people. And again, sometimes if you're a visual learner, it's easier to be able to see a video versus just read about something. At least that works for me. Lots of CEUs in there. We have specialty CEUs, and there's not a whole lot of like 0.5 or 1 CEUs. We've been putting them together so that you can get like 3, 5, 10 CEUs at a time. And again, very pertinent information that's applicable to what's going on in your coding world today. A lot of things in there on telehealth right now. Extended product support, always helpful. I know that I've been getting a lot of messages on LinkedIn with questions, and I'm always sending them to the club to get their answers because honestly, there's a lot easier to answer in the club than it is to answer in that little chat box on LinkedIn. We're going to be talking about dementia, but to do that, we need to look at the anatomy first. I always like to start there. So how many of you guys are old enough to remember the commercial that used to say, "This is your brain," and they'd hold up an egg and then say, "This is your brain on drugs," and then they'd crack that into a skillet and it'd sizzle? Yeah, I know you probably are dating yourself if you say you remember that. But what is true about that is that when we damage the brain, it's not repairable. Just like you can't take an egg and put it back into the shell. So I really liked the way they use that example. This is your brain. And again, think of the shell as the skull. The dura mater is the white of the egg, and the brain itself was the yolk of the egg, and it's all protected in there floating around. And again, you crack that skull or you do anything to damage the inside of that egg, you can't unscramble it. It's kind of what happens with the brain. Yeah, once you start having damage, whether it's caused by trauma, whether it's caused by medications, or that it's a problem inside the body itself on a chemical level or a cellular level, not much you can do to repair it. Now, one of the interesting things is when our number 5 child was born, he had problems right away. He had seizures just immediately. And they did lots of scans and tests and stuff like this. And I remember they saw some damaged areas, and the neurologist, the pediatric neurologist, when we left the children's hospital, he had told us that, we tested for everything. And we can't determine why the damage that we saw was there, or that it's caused by anything like a genetic disorder or something, or even trauma. It just the way his brain developed, probably. But he said, in a neonate like that, your brain compensates because it's developing. And he said that, he may never ever have any more issues. And sure enough, he didn't until he was 2. He did everything fine. But we knew that the brain had, was different. But when you're that young, the parts of the brain that aren't working at peak capacity the other parts of the brain compensate. That doesn't happen for older brains. And therefore, you come up with things like dementia. Now, let's look at the 2 sides of this brain. We are looking at what a normal slice of the brain would look like on the one side. Everything's reversed here. And then on the other side, we see marked differences in the brain. So the cerebral cortex folds, that's all the little wrinkles in the brain. We want to see them have deep wrinkles and really bunched together in real tight. The hippocampus also, it needs to look just like that. So it is a part of the brain. It's like a big fold in the brain. And if you look at the opposite sides, we see that it is misshapen. We see that there's whenever you think of a space, it's usually called a sinus or a ventricle, you could call it. They've got severely enlarged ventricles in there, shrinkage of the hippocampus, and notice the shrinkage of the cerebral cortex. Whenever you have anything that's a shrinkage or an atrophy, that's a significant sign of a problem. Or giant gaps that aren't supposed to be there, like these ventricle, like caves inside the brain. The brain is pushed in really tight. And, think of that egg again, and think of it having sometimes, have you ever cracked an egg and seen a double yolk? Okay, that would be fine, but if that was a fertilized egg, that wouldn't be fine. Right? There's not enough room for 2 little chicks to develop in there. They're going to have problems. And likewise, when the brain is in there nice and tight and snug, that's fine. That's what we want to see. However, when we see that the brain has, atrophied, we see holes or caves or sinuses or whatever, and pieces of the brain that that we know what the brain looks like, that it's abnormal, it's going to cause problems. And notice even here, we've got these nice large folds, but they're tight together. And then over here we have a similar, but it's got a great big gap in here, like it's atrophied and turned into a cave. The shrinkage of all of this lower part of the brain. That severe damage to the brain, therefore dementia is going to be one of the side effects. So actually, when we talk about dementia itself, what is it? It's damage or death of the brain's neurons. Now, I'm trying to think of what year in school we started learning about the makeup of the cells. I was thinking it was junior high, but I could be wrong. Or if you took probably is it physical science maybe, when you started looking at the cells and things, and all the you had neurons and protons, and you had a nuclei, and all the different aspects. We used to have to draw it and make colors and stuff like that. I really, really enjoyed studying things on a cellular level. I think I mentioned one time that I had thought that's kind of the way I wanted to go in the medical field, is pathology and science, and study things on a cellular level. But then it was kind of boring. So not that I need things to be too exciting, but it was just kind of boring after I really got into it. However, I did learn a lot. And most of the diseases that happen in the body, something is off on the cellular level, right? If there's not trauma to the body, but chemical imbalances can make a big difference. A problem with the chromosomes or the anatomy on the cellular level. Even the cancers is a change on a cellular level, right? So when we think of dementia, what is it? It's a degeneration of the neurons, and it can be just damage to them or death of the tissue. And the brain the brain cells do not grow back. Just like the heart, once the heart's damaged, that's it. That tissue does not grow back. Unlike if you damage other tissue in your body, like your skin, it may scar, but it grows back. It can fix itself. The liver, we can put a smaller piece of liver and transplant it into a person, and it will grow and develop and compensate. But the brain can't do that. And therefore, if you're going to have an injury, you want to have it younger than older. Now let's talk about how damage and death of these brain neurons can happen. When we think about where damage happens in the brain that causes dementia, you have a few choices that we know of. First of all, we could have frontal temporal dementia, and that's going to be, again, the front and the sides of the brain. And I did not grab a graphic of the different areas or names of the different areas of the brain. You can do that in your own research. You can find that anywhere. I would not say that you would need to have those memorized. It can get pretty detailed, even as to telling you what those parts control in the body. I do know some of them, but you'd be surprised. So like the back of the brain can affect is more for the eyes. The front of the brain is more personality and stuff like that. But again, it's a fun thing to research, and I'm hoping that these lectures like this will spur you to do more of that on your own, because in the medical field, you never stop learning, as you know, and you want to take what you learn in segments and then go add to that knowledge base. So we're going to be talking about the specificity for dementia. But if at any time you see something that you don't know, like a disease that we're going to mention here in a minute, we're going to talk about Parkinson's, we're going to talk about Lewy Bodies, we're going to talk about Alzheimer's, then I want you to make a note in a piece of paper, your notebook or whatever, and then go do your own research for that, because you're constantly building. Now, again, you don't have to memorize the different areas of the brain. You don't even have to remember that dementia is caused by damage or death of the neurons. That's not going to make a difference in the way you code, However, what you do want to remember is the major areas of the brain, which are pretty easy. Temporal, because these are your temples, right? Frontal, lobes. The brain is divided into two halves. We all know that, hemispheres, you know, the back of the brain. So again, there's a motor cortex, you know, the main things, but you don't have to get into all the details. The reason I tell you that is because there are different types of dementia, like frontal temporal dementia. Okay, and what does that mean? That means the damage to the brain is in the front and the temporal lobes, and because of that, we know what the patient's going to be losing mentally, what's probably going to be affected, and personality has a lot to do with that. So again, frontal temporal dementia affects those areas, but if you get Lewy body dementia, it does the frontal lobe, but it likes to also affect the motor cortex, which is a different area of the brain, more towards the center. And then you have people that suffer from Alzheimer's, and that means that the entire brain, the entire scope of the brain is deteriorating. And again, we've got some pictures of that so that you can better understand what that looks like. And also the hippocampus I told you about, that's there at the back, kind of up high into the brain, that is where people that have Alzheimer's, they usually see a significant change in the anatomy of that area of the brain. And this is the area that does memory, is back deep in the brain. Okay. When you lose brain tissue, it starts to atrophy or shrink, just like that picture that you saw, but it also widens the space and makes gaps. And what's the best way to see that? You can see it on an MRI. And so again, one of the CT scans, MRIs, they'll go in and they'll do those scans when they suspect that a patient might be they might have dementia, but they want to rule out what type of dementia. Is it senile dementia? Is it Lewy body? Is it Alzheimer's? Things like that. That's going to help you get to the highest specificity, is knowing some of the tests that are run to do that. And pretty much we're looking at, they can do blood levels, but a visual image of the brain, and I believe I added one of those. You can have disorders with dementia, and when that happens, it's usually irreversible. So you have a disorder or a disease, and the dementia is a side effect of that, but it doesn't come back. And again, we'll talk about a few of those, like Parkinson's would be one of those. Parkinson's in and of itself doesn't, it affects the brain in that it is a nervous system type disease. And usually when you think of Parkinson's, you think of that shuffle walk, and you also think of tremors, right, in the hands, but it's affecting the brain. And if you have Parkinson's with dementia, then they can go in and they can actually see that and tell that it's Parkinson's and that it's with the dementia. Just because a person has Parkinson's doesn't mean that they have dementia, but they could have Parkinson's with dementia. And in that case, it's a different code because we want to get to the highest specificity. Sometimes if there is damage to the brain or there is a problem with the brain, they can be treated. However, not usually dementia itself. So when you think of somebody having a head injury, let's say that they were riding on a motorcycle, they had a wreck, and they had their helmet on, but there was still trauma to the brain. Again, they could have memory loss. They could have some long-term effects of that because of the buildup of fluid or the bruising of the brain. And it can, you know, the bruising can go away and the swelling can go away and hopefully doesn't leave irreversible damage, as the brain can heal that way. But unlike dementia, where it's on it's the neurons that are being damaged, you know, there's no coming back from that. You can have brain tumors, also things like meningitis. That's why meningitis is so scary, because it's an inflammation of the back of the brain. And you do anything to the back of the brain, the base, that's it. That's the control center of the brain. And meningitis likes to do, it's an inflammation of that part of the brain. Hormone and metabolic disorders can cause memory problems. Hypoxia, which is lack of oxygen. Also, drug abuse and alcoholism. So there is a type of dementia that is associated with drug abuse and alcoholism. Now, I know people are pretty accepting of cannabis, unlike that they've been in the past. There are some definite notable things that cannabis does, especially cannabis oils and things that help people. Cannabis can be used for people with Parkinson's and some other problems of the brain. And it definitely helps with pain and cancer and such. However, if a person starts using cannabis at a young age, and they've tracked that through the years, it damages the brain, and especially, you know, young and progressive long-term use, it causes problems. You know, we make fun of that in movies, right? Well, there's a reason, because it does damage the brain. So again, it has its place and its use for treating. However, it could be abused, just like alcoholism can be abused, and dementia can be a result of that. And there's specific codes for that type of dementia. Now, dementia, just like diabetes and COPD, are an umbrella. You may have seen a diabetes umbrella that we've done, or we've referred to COPD is, you know, an umbrella with other lung disorders, chronic obstructive pulmonary diseases that fall under that, like asthma and also emphysema, right? So again, that is the broad term, dementia. But there's so many diseases that fall under the umbrella of dementia. The main one is Alzheimer's, that you're probably the most familiar with. And again, when you graph it out on how many people have Alzheimer's dementia compared to the other types of dementia, it is usually more than 50%. That's the type of dementia. Now, again, you can do research on that. I found lots of graphics, and you can, you know, look at those. Also, the Lewy Bodies is a big one. Parkinson's. Definitely, you can have Parkinson's with Lewy bodies. You could have mixed. Frontal temporal has its own code. Vascular dementia, unlike the ones that we've mentioned before, vascular dementia is unique in that it's usually a result of somebody having some type of stroke, a vascular problem. I wouldn't call that necessarily trauma to the brain, but maybe there's an aneurysm or something, but a TIA or a CVA, that's what we're talking about. Dementia, because of the buildup of plaque in the arteries, can cause that as well. We talked about drug-related genetic conditions. There are several named genetic conditions that when you look up a code in the index and you're looking at dementia, but then when you go and it may direct you to a more broad term, but when you go look at it in the tabular of your ICD, you'll notice that it has a long list of different names, and that especially for genetic conditions. And I think Huntington's one. I think I've got some on the other side. Meningitis would be the infection. And so let's look at some questions that I'm seeing pop up real quick. Let's just address those. Claire, hello, Claire. So nice to see you. Okay, so Claire mentioned that her husband has dementia and he has the FTD, which is frontal temporal, and it's quite different. Anxious to hear this. Okay, yes, it is. Frontal temporal affects behavior and moods quite a bit. So we are going to talk about that. Thanks, Claire. Claire is, well, I won't talk too much about Claire, but she's an old coding friend, meaning I've known her for a long time. And so good to see her name. Varun says, was waiting for this. Okay. Oh, in India. Oh my. I had to get up at 5:10 a.m. Varun, okay. Whitney, what age can you start getting dementia? Now, if it's age-related, which would be senile dementia, ultimately that just means that the brain's wearing out. It's just getting old, okay? So that is one of the more common types. Alzheimer's really is the biggest. If you go look at the graph, they've got pie graphs out there. In fact, I may still have a page up where I could pull one over and look at you when I was doing research earlier today and familiarizing myself with some of the things that we were going to talk about. The age, you could have, for example, Alzheimer's is divided up in late onset and early onset, but they also have different diseases of dementia that start, as you would think, for older people, but they also have codes for the young. So it's in the descriptions, in the tabular, when you look at them. Especially too, if the dementia is due to a genetic condition, can start at any age, right? And as well as other things like MS. Let's see, let me look again. Whitney said, can you discuss what Alzheimer's dementia is and how Alzheimer's and dementia are different? Yes, let me just tell you real quick. Dementia is the umbrella, but Alzheimer's is the disease. So dementia, I wouldn't necessarily call it the sign or symptom because that's not really a good way to talk about it. Dementia could be the end result of another disease. You might think of it that way, or the outcome, right? The sequela of a CVA might be dementia. But Alzheimer's, you can have more than one type of dementia in the Alzheimer's disease. But Alzheimer's in and of itself is a disease that changes the structure of the brain. But remember, what is the definition of dementia? It's the damage of the neurons, whether it be injury or just the wearing out of the neurons on the cellular level. And we've got some pictures of neurons because neurons kind of look like space aliens. If you've ever seen, I can't remember what the movie is, where, remember that one that they really advertised a while back where it was all these symbols and it was a white smoky room and this black figure would slap up again, kind of like an octopus, and then all the little arms and legs or the little tentacles would look different for phrases or things that it was saying. Neurons kind of look like that. They look somewhat like an octopus, somewhat like an alien octopus. Okay, so we'll talk about that a little bit. Let's see. Lisa, my neighbor who is a nurse practitioner, told me in her test, one of the questions on her test was, how often does dementia come with Parkinson's? And the answer was 100% of the time. Yes. When a person gets Parkinson's, they can have dementia. So it's associated, so much so that they've got their own, it's got its own code. But the patient may not have the dementia that we think of as dementia. They may have forgetfulness and stuff like that, but it's what is dementia? Dementia is the neurons being affected, okay? And how that exhibits itself may not be in what we would say in the lay world that they were having trouble remembering things. So an example, when people worry about losing their keys and they think, oh no, maybe I have Alzheimer's, especially when they get older, right? It's really probably not that. It's just that they're too busy and they can't remember where they put their keys, right? Alzheimer's is where you don't remember what the use of a key is, what a key is used for. Okay, it's not that you lost your keys. It's the fact that when you find a set of keys, you don't know what a key is or what it's used for. Okay, so that kind of explains. Parkinson's would be similar than that, but you have more of a senile type dementia, the way I understand it. And the best way to find out about that, Parkinson's is considered Lewy body, and we're going to show you the difference in Alzheimer's and Lewy body dementia, which Parkinson's is Lewy body. And you're lucky that your neighbor is a nurse practitioner, because you always have somebody to talk to and increase your knowledge base. But I really, really like the example of the umbrella. Use that with other diseases like COPD, and as in there's a lot of different diseases that fall under that one term. So dementia is a very broad disease term. Lots of things can be dementia. That being said, let's just now start looking at some of the codes, and then we're going to kind of divide these up. The first thing, if you just go look up senile dementia or dementia because a person's getting old, then it's going to, your index is going to direct you to F03.90. Now, there are two areas in your manual codes that affect dementia. F, remember, has to do with the psychology, right? I remember F is how you're feeling, or remember when I used to say the funny farm? Yeah, different things that are associated to mood is going to be codes that start with F. However, when we talk about the brain and the central nervous system, and even the peripheral nervous system, the PNS and the CNS, those are G codes. Now, how do you remember the G codes? Well, I think of them as Agatha Christie's character Hercule Poirot, who used to say, the little gray cells, get your little gray cells, thinking, and that is the medical term for the brain's gray cells, because when they come out of the body, they look gray when there's no blood supply. And so those are G codes, anything that has to do with the brain itself, the central nervous system, or any disorders of the central nervous system or the peripheral nervous system, we are looking at codes that start with the G. So dementia, just senile dementia, doesn't that seem odd that it starts with an F? But it's a neurodevelopmental disorder. Mental, behavioral, and neurodevelopmental is going to be an F code, F01 through F99. All the codes start with an F. So we've got mental, so the ability, the cognitive ability, behavioral, moods, and neurodevelopmental. So the fact that the neurons are affected in the brain, and they're not they've either not developed anymore or they're damaged or whatever. That's why it's an F code. Degenerative neurons. And then it breaks down and says that the F01 through F09 are mental disorders due to a physiological condition. So again, mental, memory, think of it that way. Why? Because a physiological condition is happening. Thus, the neurons in the brain are degenerating, or there's a problem with the neurons. That would fall under dementia. Then we break it down a little bit more, and if it's just dementia that's stated in the documents that you're coding for, it's going to be an F03. That's going to be your starting place because that's unspecified dementia. So the provider just states the patient has dementia. We don't know what type. And there is a lot of different types of dementia. Then we're going to go with F03.90 because that's unspecified dementia. We have no other information, but we also don't know if there's behavioral problems. Why do we think about behavioral problems with dementia? Because dementia is not only a neurodevelopmental disorder, but it's mental and behavioral. And we often have behavioral issues with dementia, so it's built into the code. So let's talk about that, because when you want to get to the highest specificity, you do not want to use F03.90. That is way too broad. So again, that could be the beginning of where your starting place when your provider says, okay, all our signs and symptoms are telling me that this is probably dementia. I'm going to diagnose dementia. And then we're going to do further testing. We're going to do scans. We're going to do some blood work. We're going to do a psyche valve, neural, muscular, physical, and see where we're at. Okay, and then we can code to a higher specificity. Also, interviewing the family and the counseling. So let's say this is a husband and we want to talk to the wife. Are we having behavioral issues? Are we having outbursts, mood swings? Is he depressed? Is he up one minute and down the next, right? And then, confusion. What are you noticing in confusion? I read charts a lot where the spouse is concerned, and predominantly these geriatric patients, not always, but the project I'm working on is now. And driving, got lost driving, and in a trip that should have taken 15 minutes to drive, to the post office to pick stamps, took an hour because they got lost. And or they stop and they're confused and they can't remember where they're at, on the way home. That's a problem, and that's where they'll get a higher specificity asking questions like that. You may also see in these charts that they'll do a clock test where they'll have them draw a clock. They'll give them a piece of paper and draw a clock, and so what they want to see is the circle. They want to see all the numbers around the clock starting at 12, 1, 2, 3. Are they in the right place? Do we have 12, 6, 3, and 9? Did they put then they'll even say, okay, show me 3 o'clock. And so did they make one hand go to the 3 and one hand go to the 12? And then even better, did they make the long hand go to the 12? Things like that. If you can do that, then you're snapping, right? If you can't do that, even draw that circle, that can be a problem. And there's other tests that they do that have names, whether they have you draw not a box, but it's not a hexagon. I don't remember. I think it's got 6 sides. I can't remember. They'll have you draw it or they'll show you a picture and they want you to replicate that. So these tests are all tests that get done when a person gets their initial visit with Medicare. because they want to start and see where your level is at cognitively. Okay, so I've got more questions before I go to the next slide. Let me go look at these real quick. Okay. That is interesting, Lisa. I have a relative who has battled Parkinson's for years. He has had a neural implant to try to help him. Yes, that's one of the things they do. Let's see. He had a neural implant, but it didn't help. Okay. Too long. He has gotten to the point of dementia now, and he doesn't recognize his wife sometimes. And again, it's related to Parkinson's, not Alzheimer's. So it's a different type of dementia. I think I saw a patient one time who had dementia and were in their 20s, and they had suffered a TBI, and the dementia resulted. So the doctor documents dementia and nothing else. We just code the F03.90, yes. If the doctor does not state that there is behavioral disturbances, then it's without behavioral disturbances. You default to without. Very good questions. Okay, let's look a little more into that. When you look at your index and you go and you look up the dementia and you get to the F03.90, the unspecified. However, you will still see on that index with, right? And it's going to say aggressive behavior, 0.91. Now notice you see that more than once. So if we have aggressive behavior, behavioral disturbance, or combative behavior, then you're going to be using the dementia code for F03.91, not F03.90. Don't put those in there if they don't give it to you. You default to without behavioral because you can't code it without. It's not unspecified dementia with unspecified behavioral disturbance. That's not an option. Okay, now then another choice under with, so we've got dementia with, is Lewy bodies. Now, every time you're going to code for dementia, no matter what, they're going to want to know, is there behavioral disturbances? So you're going to be looking for that. And your provider is trained. That's part of the disease process. So they're going to document that. Very seldom are they not going to document that. Okay. If they don't, then that's an opportunity to query. But you don't see that left out very often. It does happen. Okay. So now we know with the behavioral issues, and then we have things like with Lewy bodies. Now, notice there's two codes associated with that. F02.80, but the code is G31.83. Parkinson's is G20. And that's Parkinson's disease. And Parkinsonism is G31.83. Okay. That doesn't feel right. Seems like Alzheimer's was the G20. I'm thinking, yeah, I think so. I don't know. I copy and pasted that from the thing. That doesn't seem right. I think G20 is Alzheimer's disease. But anyway, we'll go look it up. Make a note of that so you can check it to be sure. When do you code altered mental status or disorientation? It has to be documented, and then you would add that to the code, and it's built into the code. So this is what it looks like. I picked vascular dementia. So again, we already talked about vascular dementia is that, yes, we have a problem with the neurons, but why do we have a problem with the neurons? Because of something in the vascularity of the brain itself. So the code F01.50 is that vascular dementia without behavioral disturbances, because it wasn't mentioned. But this is also considered major neurocognitive disorder. Okay, vascular dementia and major neurocognitive disorder is the same code. If you have behavioral disturbances, then notice all of the list that falls in there. And it's mostly just repeating aggressive behavior, combative behavior, violent behavior. Okay, but all of those terms mean vascular dementia, and that behavioral disturbances are part of it. Okay, you don't specify, oh, they have aggressive and combative. That's not two separate codes. It's just F01.51 encapsulates all those codes. However, notice that if it's vascular dementia, then we want to know, is there an underlying physiological condition? Like, did the patient have a CVA? Or is there cerebral vascular disease involved? And if so, then you're going to code that first. Okay, so the patient has cerebral vascular disease. They have a clotting of the arteries in the brain, you know, or whatever the issue is. And as a result, they also have F01.50 or 0.51. So the dementia is coded with that. Now, there is another area to get to the highest specificity that we want documented. And you think, why do they have this code? Because we need to track it. That's why. And that's if the patient has vascular dementia and they wander. That means they get lost, they wander off, and they don't. This is when you hear of people living in a nursing facility and they wander off. That's what they're talking about. So they have dementia, but they're wandering off. Okay, so we need to track that. So Z91.83 is wandering in vascular dementia. So in other words, they walk around and they just don't know where they're at. Okay, and that will be documented as well. Don't code the Z91.83 unless it's documented, right? And they use the term wandering, and that's what it means. They wander off. But again, if it's vascular dementia, then there probably is a reason why they have vascular dementia. Vascular dementia is kind of a broad statement. So what happened to cause the vascular dementia? And use both of those codes to describe what's going on. A little more information about vascular dementia I wanted to talk about so that you would be able to get to the highest specificity is, what if a person had an infarction of the brain, which is just a blockage of the vessel, or they have arteriosclerotic dementia? Then what you're going to see is that they have a history of problems with the blood supply in the brain. So they've had multiple TIAs, which is a transient ischemic attack, which lasts for just, under 5 minutes. It's like having a stroke, but it's real short. Or they've had a CVA or a stroke. Okay. And then they could also have hypertensive cerebral vascular disease. So they have high blood pressure chronically that is so high that it's like messing with the vessels in the brain. Now, note that you can confirm those cases of vascular dementia by a CT scan, or they can do neuropathological exam, but most of the time they'll go in and they'll do they'll go and scan them, and they'll be able to see the atrophy of the brain or the damage of the vascular system to the brain. However, they can't tell behavioral disturbances via a scan or a blood test or anything. That has to be done by observing or monitoring it, or that history of family and loved ones or nursing staff. So when they talk about verbal and physical, they can have mood, they can have thought and perception, so they don't have the reality, sleep, and they can also have sexual and or appetite changes. So a person that when you go into a facility and you hear somebody screaming repetitively, that isn't that they're being abused. They probably have some type of dementia, right? Also, dementia, especially things like Alzheimer's, will make you lose your inhibitions. So where a person might have been a good little Christian woman growing up, very reserved, private, and quiet, dementia hits and extremely different, right? The extreme opposite. Also, the physical, they grab at you, especially when you're walking by. They grab at you. Yeah. Mood, again, easily irritated for no reason. I remember one time I was working at a skilled facility while I was in college, and one lady, she always kept a stuffed animal with her, but she'd sitting her walk, she would sit in a wheelchair, and she's the sweetest little lady, and she would stare at the wall, and she thought she was looking out the window, and she would stop me. She'd grab you, and she'd say, "Look, did you see that? Come here. Look, did you see that?" And you'll say, "What? What did you see?" She goes, "That bunny. Did you see that bunny under there, that bush? Wait, he'll poke his head out. Just look, wait, see him, see him? Did you, you know?" And it was same wall, and there were nothing there. And then, and usually, you know, she was usually a very happy person, but every once in a while she'd just cry for no reason, you know. And so again, it was a hallucinations, delusions, things that aren't normally there. Jennifer, Parkinson's is G20, Alzheimer's is G30.9. Thank you. I kept looking at that thing. Something doesn't look right on those codes. I was looking at them because you know how when you code them all the time, sometimes they get confused. Genetics is a big part of whether or not someone gets Alzheimer's. Yes, I've done a lot of research on that. I read somewhere that working word fine books every day could help you from getting Alzheimer's, since you keep your brain working doing this. What do you think? Who knows? There's a lot of people that say that that is true. And I would say that even though your brain is not a muscle like your heart, because you want to keep your heart going like a mean, lean fighting machine, right? I think you've heard me say you want your heart to be a Corvette. You don't want it to be a one of those big old Cadillacs or Suburban or SUV. You want it lean, mean, and running machine, you know. And then you don't want it a Ferrari either. Or definitely not a DeLorean, because I think they made the joke that you had to get it up to 88 for the Back to the Future, but that was only because a DeLorean never went over 88 anyway. That's what my husband said. So again, anytime you exercise the brain and keep it functioning, yeah, I think it's always a good thing. There's a lot of other things that they attribute to dementia. There's one that was a certain type of herbicides. Some of it is just hereditary. Your body is predisposed. Maybe it's a chromosome, you know, that is different, that they, you know, there's lots of research around different types of causes of dementia. So I would urge you to go look, but only trust the sites that you can validate. So I'm not going to go to Wikipedia and see what prevents Alzheimer's. You're going to go to Mayo Clinic, WebMD. You're going to go to alz.org, where I got some of this information, which is Alzheimer's, for Alzheimer's. Let's look at the codes a little more in depth. Okay, so I told you about vascular dementia is going to, now these codes are broader, all right? I should have put the point dash on there to let you know they're expanded here. But if it's going to be a vascular type of dementia, it's going to be an FO1 code, and we already looked at some of those. If it's going to be a dementia that is associated with other diseases, then it's an FO2. If it's unspecified dementia, then it's an FO3. If it's Alzheimer's disease, that's a G30. Okay. Now, you'll recognize the frontal temporal dementia, and that is going to be other degenerative diseases of the nervous system, not otherwise specified, G31 codes, and it's further divided, and it's going to be frontal temporal dementia, other frontal temporal dementias, and senile degeneration of the brain. Okay, so again, senile dementia, G31. Okay, so then I took the G31 and looked at G318 because this is important. These are two really common ones that I see in charts. G31.83, dementia with Lewy bodies. Okay, and we're going to talk about what that means, how they know it's Lewy bodies, and mild cognitive impairment, G31.84. So again, we have a type of dementia going on, but it's cognitive impairment. And some of this is just happens as you get older. Your brain just doesn't snap like it used to. Everything in our body ages. And so that doesn't mean that you're senile or that you have, dementia. It's just the fact that your brain is not on top of clicking like it used to. Okay, mild cognitive impairment. And cognitive just means, what you know, more or less. So let's talk about that Lewy bodies because it's important. Lewy bodies is a protein. Now, I don't know, alpha, I think you pronounce that synuclein. I think that's how you do that. But it's called AS. You'll see it abbreviated AS, and you'll see it with the Alzheimer's or Parkinson's, that the nerve cells of the brain, there's a chemical reaction that interferes so that the nerve cells themselves are not functioning. So again, let's go back to what is dementia? The neurons are affected. That's the nerve cells, okay? But what happens here is we've got a protein that's clogging up the function of those nerve cells. That's, if you want to know how I remember Lewy bodies, I literally think of Lewy as a thick substance, and it's ooey. Ooey Lewy, ooey gooey Lewy. That's how I remember it. Okay, you can remember it any way you need to. Let's see. Darman says you could put out a list of how you remember the letters. I remember that G is gray matter. Yeah, and J is the J tube. Yes, the rest. You're right. You're right. And because if my brain associates terms, then I can remember them. Otherwise, I can't. So Lewy is ooey gooey Lewy, and that's what it does. It's this protein that clogs everything up. And when I picture it in my brain, which I hope I never have it in my brain, I think of it as this white goo that clogs everything up. No, I know what I think of it as. When you make pasta and the water, the starchy water, when you drain the pasta, if you have one of those drainers where you can just take the pasta out and put it in another bowl, and that water, starchy water's there, which you can use to make like other things, breads and stuff. It's starchy, filmy, right? That's what I think. Lewy, ooey, gooey. Okay, so what happens is it just changes the mental status because this protein clogs up the process. Ultimately, it can cause things like not being able to pick something up. Now, I'm always got something in my hands because if I'm not talking with my hands, I've got my things here's a pen that I got the other day that I really like. And I've been playing with this hair pen, while I'm talking to you. But let's say you go to put this in your hair, and you can't make that work and everything. So that's a disordered movement. Visual hallucinations. How many times, especially as a child, I remember, you see a shadow out of the corner of your eye, or you see something, that's normal. Even seeing little floaters in your eyes and stuff. I remember when I was a child and I first saw that, and I thought that was so crazy. I was worried that something was in my eyes. But again, you're seeing things that aren't there. Also, personality and behavior. The Lewy bodies is associated with Alzheimer's and Parkinson's. So you're going to see that in the code description in the tabular. And Lewy bodies, you'll see it with Lewy bodies. And if the documentation says Parkinson's with Lewy bodies, that's a different code. So you want to make sure you capture that to get the highest specificity. Whenever you are looking at the diagnoses, pay attention that sometimes they will have those combo codes, those two codes. You'll have a G code and an F code. Okay, and there is no cure whenever you have dementia with Lewy bodies. Really, there's no cure for dementia, period. You treat the signs and symptoms and everything, but the fact that with Lewy bodies, it may be somebody young or old that has that, because it's a problem with the protein buildup. So I think I have a picture of that. There we go. Remember I told you that alien right there? That's a neuron, and there's a little nucleus of the neuron, and there's a Lewy body. See this right here? The Lewy body. All this has been stained. It's purple. But that's not supposed to be there. Now, if you look at it from that size, right, versus this microscopic thing that it's really there, you can see how that will mess up the ability of this neuron to do its job. Right? It's just like having abnormal cancer cells. So when you see this, then they know that's Lewy bodies. Okay, and when it's dementia with Lewy bodies, that's G31.83, and they may just say Lewy body dementia, but if it's dementia with Parkinsonism, okay, so your code at the highest specificity is going to be G31.83. Lewy body disease. There's these little extra proteins that the body is producing. Now here is a great graphic, which you can go Google this graphic, and I put the links in the resources slide. So when you're in the club, you club members can go in and you can look at these and do additional reading. It'll be very helpful for you. Again, this is showing the different types and where the Lewy bodies affects what that part of the brain is. It starts out in stages. So here we are just a little bit, then we're getting more develop and pushing out, and then all of the brain is affected with these Lewy bodies. All right, guys, that's it. Do we have any more questions? Any more questions? Give you just a second. I think we did pretty good on time. Yep, we did. I get rid of this. Remember I told Boyd I don't know if we'll be doing an hour or not. In the meantime, no more questions. Then there's the resources that I used. Some great research that you can go in and learn more about Parkinson's disease, the Lewy bodies associated with that, and the different type of dementia. You could study all day about Alzheimer's. So I would encourage you, yes, to look at Alzheimer's, but don't let that be the only thing that you do look at. There's other types of dementia, and you need to be able to be very aware of the different types so that you can get to the highest specificity when you have that documentation in front of you. Okay. You need to know the key words to look for, and they can identify to a higher specificity, especially after they have a scan. They're pretty good about getting that done right away. Neurologists is who they're probably going to see, so go and reference the neurology reports. Yeah. Okay, so again, thank you, club members. And if you're not a part of the club and you're joining us on one of our other social network platforms, feel free to check out the club, cco.us/club. Maybe you have a topic that you want us to break down and look more in depth to. So there's a topic request area, or you put it in the club, and of course we'll research that for you. And next week we'll be having our public Q&A webinar. And I know that we've already got 3 topics picked, got 3 more topics to go. So if you got something you want us to talk about, go to the club, let us know. All right, bye guys. Have a